My brothers were very closely associated with my father in business. I loved business too. My father was a grocer, and what I enjoyed was meeting people of all social levels, ethnic levels, and racial levels or whatever. I enjoyed working with people. I had a great deal of respect for physicians, and I felt it was a very noble profession and very prestigious, something that when you have respect for, it sort of gives you an interest in, and plus the fact that I found my academic interests were directed mostly to the sciences. It was either that or I even thought of law, and I sometimes wonder maybe did I make the right decision, but I never regret what I did, truthfully, because I enjoyed history. I enjoyed reading about the history of medicine and the backgrounds in medicine and so forth. But I found that I had an aptitude in the sciences, and in high school I found zoology, biology, chemistry, the inclinations towards the sciences. There were certain people who always had, you can look at, who had a great influence on you as far as teachers. I was very fortunate that when I was in grade school, in fact, towards the 8th grade, we had a man who came in who became our principal at West Boylston Street School here in Worcester. It's no longer there because the Expressway 290, I think, has gone through it. But Leo Ivach, I owed a great deal of debt to. In being in Worcester, it would only be natural that maybe I'd go to Holy Cross or go to Clark or go to Assumption. And he directed me to Harvard. And so it's the only school I applied to. So my inclination at Harvard was to be pre-med. Again, I found that the science courses were where I had my aptitude. As far as I could see very clearly that I wasn't going to be going into the literary fields. I was a C+ English student, but I found that the sciences came more readily, and and I had some excellent teachers in college. And so when I applied to medical school, in fact, I had an interview for Harvard, and when I was interviewed there, I was more or less given the word that I've always been Northeast in my training and orientation. Maybe sometime or other I should get some part of my training outside of the state. They were accepting very few from my class to Harvard, maybe 1 or 2, whatever. And anyway, I was accepted to Georgetown without even an interview, which is, I'm just saying, this was back in '49 when I was accepted to Georgetown. So it was sort of a natural tendency where I had an attraction to, an inclination to what I would go into, and medicine is what attracted me primarily to become a doctor. I think you may want to get to the next question, how I went into a particular field, but I found medical school a tremendous experience, and it again reinforced everything I felt about becoming a doctor. And in that era, I think that our professor of anatomy started us with our first lecture, and of course at a Jesuit medical school, not that we were necessarily religion-oriented, but he gave us an example that, gentlemen, you should think of your education as building a cathedral that's going to last for a long time. So make sure your foundation is solid, and as you build every block, it's going to be an integral part of a great experience, and that'll stand you well in your future. So that it continued on in medical school. We had teachers like Jagers, who had an encyclopedic knowledge of medicine, and was famous for the Jager syndrome, or the melanotic lesions on the lips with intestinal polyposis. And we had people who were outstanding, who taught us about continuing our medical education, which we didn't need that later on to be regulated by people who said that you had required to have CMEs. Well, we were indoctrinated in continuing medical education forever, and so And to this day, I still get my New England Journal, and I get my SGNO from American College of Surgeons and so on. Go ahead.
So you went to medical school at Georgetown?
I went to Georgetown, yeah.
What year did you graduate?
In 53.
53. Do you remember approximately how much it cost to attend?
Well, it's wild you question that, because I can give you exact figures, because when I got out of the service, we had the GI Bill, and when I started Harvard in 44, by the way, Paul, tuition was $400, okay, for Harvard. And then when I got back from the service, I think it might have been 500, but the GI Bill paid for my tuition for the remainder to get my BA degree. And it paid for my first year of Georgetown, which I think the tuition was either $500 or $600, and then we used to get $75 a month stipend. And so my first year of medical school still was pretty well encompassed with my GI Bill. Thereafter, there was a little increase each year, so that, as I recall, my last year, from 1952 to the last academic year, graduating in 53, that last medical school year, it was either 900 or 1,000. Let me just add to that our most recent visit to Georgetown was for my 45th reunion in 1998, and we had some very interesting lecture room presentations in our old classrooms and so forth. And one was regarding what the cost of Georgetown is now, 1998, about $30,000 a year. So there's quite a difference. I would say that it's risen exponentially, and I think that I don't know, 30 times that, but it's relative in many other ways. So I don't know how you compare that relative to other things. I'll mention to people that I bought my first Cadillac in 1959 after I was out in practice a year, and I was doing very well, and I paid $4,500. I bought my latest Cadillac and paid $45,000. So that's 10 times. In medical school, 30 times. So I can tell you those exact figures, and it's just incredulous that it's risen so much, and that's why I certainly feel that you're entitled to a respectable remuneration for your education and your knowledge and your efforts. This is why people don't appreciate what you put into to acquire your education. And it's not only the $30,000 a year that a student's paying for Georgetown, but the loss of income in those 4 years that he could have been making even working at McDonald's. So people don't take this into the calculation for what your education represents in dollar investments. But there's a lot more to what you get out of it, too, besides the dollar element. There's no other profession that will ever return to you the satisfaction and fulfillment that you have of being a physician. And I know a lot of priests, and I've known bishops and cardinals, and I don't envy any of them or feel that any of them has done a more noble profession than being a physician. I really do. So I've always been very, very satisfied that what I chose. I married a nurse from Georgetown. We've raised 5 wonderful children, and I think it's been part of my total life return for being a physician, that I feel very gratified that what I did was choose the right profession, and I just think that anybody who's doing it deserves a lot of respect and credit, and that's why I was willing to come and meet like this, and if anything, try to reinforce your own feelings about, you're choosing what is going to be a great experience for you, and not to feel any times, because anyone can, a certain amount of reservations about, well, is it worth it? It is worth it.
I'm very idealistic.
Yeah,
so
yeah. I think you need the idealism.
I've always felt like it's, I'm sure, I hope I always do.
Yeah, I'm sure you will.
Did you have to take out any loans for medical school at all?
Well, no, I didn't. And it's interesting because I think we were a little more thrifty, perhaps, than our generation of children are. And we Because our expectations were a little different. I didn't have a car till my second year in medical school, and it came in handy because then we had our groups for affiliations at the different hospitals around Washington, and we would alternate our cars and so forth. So I didn't get my car until I was a sophomore in medical school. Now my children, the oldest daughter had a car when she went to BC. I have one son. He had a car when he was in high school. And so it goes down the line. I wasn't married till right after I graduated. Very few in my class were. So when I was in medical school, as far as the finances, no, my parents might have added to their mortgage. I don't know all of that, but I was never told that it was a tremendous burden on them. I know that my parents were not extravagant. As I said, my father was a grocer. In a business, and a lot of his time, he didn't believe in vacations. He was always in his business. Took very little time off except to come to my graduation. So we took no loans. But I also respected my parents' hard work, and I wasn't very extravagant. So I lived on $25 a week. I lived in a private home at Georgetown, near Georgetown, and I think it was $45 a month for the room. I shared with another fellow who had been at college with me but hadn't been drafted, and he had gone on to Georgetown a couple of years ahead of me, and Frank Gerard, he was a senior when I was a freshman, and I roomed with him the first year, and he graduated in '50. And I stayed on with that family, and then as far as paying about $45 a month for rent, and then as far as my weekly necessities, we'd eat the greasy spoon down the corner or something, and it was about $25 a week. I'd cash a check, and my father would send some money. So that's the economy. As I said, we were a little more sparing than people are today. Your generation, but I think that, it was the times were like that, and I didn't feel that I was deprived. It was just the way it was, and my parents didn't restrict me that I couldn't come home if in holidays and so forth. And one of the nicest things was in the sophomore year, around when I came home for Christmas vacation, there was a car in the yard, and it was a Plymouth coupe, a two-door, and it had a Christmas card on the steering wheel. It was Merry Christmas, and it was quite an experience. And where to have a car, a set of wheels, Yeah. But the parents did not take out loans. They might have. As I said, added to their mortgage or something, like people do their home equities now. But I didn't find that it was that great a burden, actually.
So after you left Georgetown, you went on and did your internship?
Well, as I said, I came back to Worcester. It was a matter of, this is where I had gone to high school. I had grown up in Worcester. I applied to and was accepted at Worcester City Hospital. A few of my classmates went to St. Vincent's Hospital. In fact, is your wife a nurse, I may ask? Or
No, she's
not affiliated with.
She's going to be a guidance counselor.
Great. My wife was a nurse at Georgetown University Hospital. My class cleaned out a number of nurses from Georgetown. So my wife was a nurse at Georgetown. We came back to Worcester. She went to work at St. Vincent's Hospital. It was the old hospital. They were just building the new one, which they more recently gave up to go downtown. Bishop Wright had come to Worcester, and he, a few years before, he was establishing the new hospital up in the hill. And so my wife went to work first in the old hospital, then new. I started my training at Worcester City Hospital. Worcester City Hospital was comparable to Boston City Hospital in a way. It had an excellent house staff program. In fact, as they started, prior to my coming, they had 2-year internships. With my group, it was going to be a 1-year internship and then go on to residencies. And when I started in '53, then in a rotating, internship, excuse me, through medical services and all, which was a good background for whatever field you're going to go into. And City Hospital started an educational program. They brought in a Dr. Uhl, who was medical director. He was setting up programs a few times a week, would have conferences or CPCs or whatever. It was a very good program at City Hospital. And you had a diverse clientele of patients at City Hall, the indigent patients, plus you had the attendees who had private practice patients too. So it gave you a good cross-section. And as far as the emergency room service, it was the tops in the city, because the ambulance drivers brought everybody with trauma to the emergency room at Worcester City Hospital, which was to the complaints of St. Vincent's or Memorial, who wondered why they weren't going there. In fact, the bishop once wondered why the emergency cases were going to city. He said because they had the best facilities. We had a shock room, we had everything. So the City Hospital gave an excellent training. It had a volume of patients. In your general rotating internship in the medical services, you had a very busy service. So the volume was there, and it was so that's where I started my internship. And what evolved into going into surgery was that, and finishing may I go on to that?
That was my next question.
Yeah, as I finished was finishing my internship, now that's 53, 54, making a decision. It was either OB/GYN or general surgery, but I was attracted more to general surgery, somewhat more by the kind of the staff that we had in general surgery. We had some outstanding surgeons at Worcester City Hospital. There was Dr. Croce, who was an outstanding general surgeon in the city. And we had people like Dr. McCready, who was Mayo trained. We had Dr. Tom Healy, who was Harvard trained, Boston City Hospital trained. We had some outstanding people in the general surgical division. So this more or less attracted me to go into general surgery. And so in 54, I went into a surgical program, a 4-year program. And by the second year, but now this is, remember, the time of the Korean War, so guys were being drafted. I had active service in World War II, so I wasn't in the V-12 or ASTP. My service was as an enlisted man, and it was active service, so I was not eligible. Plus, then I was married and so forth. But I had had my service in World War II, and so I was not subject to the draft, and I could see that I had an excellent opportunity to carry on my 4 years. Whereas the number of people in the department was reduced, and in the second year I was working with the chief surgical resident, doing immediately indoctrinated to do cases that otherwise I wouldn't have done till the second or third year. And there was such a variety of cases that it gave me an excellent surgical training in general surgery. And I even rotated through neurosurgery. I went with Dr. Comedy to Worcester State Hospital and did few prefrontal lobotomies with him. And so I was on the neurosurgical service doing tracheostomies for him and various things, and working with him on the neurosurgical service in my first year of general surgery. I worked with orthopedists at Worcester City and the urological service and so forth. So it was a good background in general surgery, and then progressed on so that by the 4th year as chief surgical resident, I had done so many cases that I was letting my junior resident take over a lot of the cases. In those days, we were doing a tremendous volume of gallbladder surgery with a lot of surgery and gastric surgery. With a day of different types of gastric surgery. Many of it was subtotal gastrectomies, total gastrectomies for ulcer disease, and so a lot of abdominal surgery for colon cancers and so forth. So that was a great variety of work there. So that I finished my residency as chief surgical resident at City Hospital in June of '58. In my third year there, I also had 6 months of pathology. All these were such a help to me in my background, so that when I took my boards, I passed my Part 1 boards immediately. Part 2 boards were part oral and with some pathology in there, and the specimens put on the table were just things that I'd seen through my 6 months of pathology doing autopsies and gross and microscopics, so that I had a very good background. So I passed my boards, Part 1, Part 2, and then I was accepted in the American College of Surgeons. I've since then still retained a fellowship. So I had the credentials, which I have always felt important. I think that people say that, the day I passed my boards, I was no more wiser perhaps than the day before, but I think credentials mean something. And I think as time went on, it showed that even when Medicare came along, a lot of the government programs, they wanted to know that people were board certified and so forth. A lot of people use the term they were board eligible, but it's a big difference between board eligible and being board certified. In fact, that category really, I don't think that the board ever really recognized that. You might have been eligible to take the exams, but it was a matter of you had to pass it. It was so that to have the to be able to say you were board certified. So it was. I felt that I had a good background in my training, and then I made a decision where to go to practice. Would you want to go into that?
Question you.
Okay. Well, I was Worcester born and Worcester raised, and so that was one of the things that attracted me, as I said, to come to Worcester City Hospital. But then, as a matter of when I was finishing my residency, I was informed by some of the senior surgeons that, well, just because I had taken my training at City Hospital didn't mean that I would necessarily have privileges, and I sort of laughed at that, because I said my father was a businessman in Worcester, and he knew congressmen, and the city manager was a customer of their store, and so my father had connections. Not that I ever intended that I needed to use them, but I went out to practice in Webster, which was a Polish community, and I speak Polish, and so that I felt that it was nice to go out to an area where they might like to, my being Polish might not hurt, might even help, whatever, to establish a practice. But even more so than that, the fellow who preceded me at City Hospital 3 years before had just established a surgical practice in Webster, where they had built a new hospital in 1956, and they had wanted, when he went out there, an attending, a general surgeon who would be resident and practice in the community. There were certain surgeons of his era, of our era, who would prefer to practice in Worcester and maybe go out to Webster District Hospital at that time on an itinerant basis, whatever. But the trustees more or less wanted somebody established there, so he went out there. His name was Dr. Murphy, Dr. Clarence Murphy. He had been a resident at City Hospital, and so when I was in pathology my third year of residency, I was told that he was doing quite well out in Webster. So that as I was finishing my final year of residency, I contacted him, and he was really had a tremendous practice, and he certainly was very anxious to have an associate. So we visited out there and found that it seemed very interesting, very attractive to go out there. And so we became associated in 1958. I went out there, and we had an arrangement where we would alternate time off and so forth and so on. It's interesting because some of our contemporaries in the city who were surgeons at Worcester City or at St. Vincent's and whom I knew, they were in solo practice, and their time off was a little different and so forth. And I thought we had a very good arrangement where we were associated together, covering each other, assisting each other and on the big cases and so on, because even at City Hospital's resident, I knew that when we had a big major abdominal case that the surgeon needed a good assistant, so forth, and we were both board-certified surgeons, one helping the other. In 1958, I started with him as associate. In 1960, we established an equal partnership with an association. It's called Webster Surgical Associates Incorporated. And so that was in 1960. And we continued on, as I said, having an arrangement which gave us an opportunity to take time off. We worked alternate weekends, and if we were off a weekend, it might, in the summer, might even include Monday and so forth. So we worked hard. We had a very, very busy practice, and we were the envy of a lot of the surgeons in Worcester. When we'd go back to our meetings at Worcester District Society, they knew we were the two busiest surgeons in the Worcester County area, which we were. We had a community of about 35,000. We were the only two surgeons, and we had a tremendous referral base. And so this continued till '83, when my partner took ill, and he came in one day and had some chest pain and had an x-ray taken, and I thought he had a lesion in his chest, a neoplasm, whatever. I called Brownie Wheeler, whom I knew, when he saw him, and it turned out that he had an aneurysm of his ascending aorta. And so he had a procedure done by Dr. Vandersoem in April of '83, and after that didn't come back in full-time practice, and our surgical association was then discontinued, and he did a little bit solo practice after that, and I continued solo then from '83 till '89, with all the different changes coming about and so forth. I began finding that by '88 or '89 that I might be thinking of a career redirection. So we'll get into that if you direct me to some other question.
So take a step back.
Sure.
What was a typical day like for you when you first started practicing? Was your practice really busy right away?
Yes, it was, and that's what I liked, because I came out of a surgical residency in gung-ho, and so in fact he would just soon take some time off, my associate. So in fact he got divorced and remarried that summer, but he had the occasion to want more time off, and I was anxious to get busy, and we were very busy. As I said, we had a full surgical load every day of 4 or 5 cases, and a very busy office schedule and so forth. So the office would both be in the office maybe 2 to 5 on the days we were in, and then going back to make rounds, and when we finished in the office, before I went home for dinner.
So what were typical hours like for you?
Well, I'd go in for surgery starting at 8 o'clock, so that I'd like to get to the hospital about 7:30 and see my patients from the previous day or the pre-ops for the coming day. And because as a community hospital, we had very close, our hospital census was, say, about 65, and they were medical, surgical patients and so forth. We had a pediatric ward too, but I'd make just brief rounds when I'd come in the morning to the wards, and any problems with the post-ops or anything, and then see the pre-ops or ask questions about the pre-ops and so forth. So we had a very close relationship with the nurses, with our patients, and with our OR personnel and so forth. So we'd start surgery at 8 o'clock, and maybe by 10 o'clock or so forth, after we'd finished a couple of cases, we'd have a break, coffee break, and then resume operating, and operating into maybe 1 o'clock or so. maybe have a sandwich up in the OR or something. And surgeons work differently from internists. You know, we're more adherent to our, not that they're not, but we have a strict schedule, and we have to, when the cases are to be done, we do them. And so we'd finish maybe in the OR 1 o'clock or something, and then get down to the office from 2 to 5, and maybe a little later. Now, office practice would be seeing patients referred, and did a lot of office minor surgery too. Did a lot of diagnostic procedures too. Did a lot of sigmoidoscopies. Did a lot of gynecology in our practice too. Because in our surgical training, we did a lot of gynecology. In fact, in the surgical practice, when I first started in the early 60s, our obstetricians in Webster were not doing sections. So if they needed a cesarean section, it was my partner or myself would do sections. I was called in many times in the evening to do an emergency cesarean section for the obstetrician who had a problem. So that we gradually, as I said, over the years, some of the general surgical aspects of our surgery changed. We did initially we used to do a lot of TNAs, for example. But when we got otolaryngologists into the community after 5 or 6 years, we were very happy to hand that hands off. We didn't want the post-op bleeders or any of those things. So we were very happy to give that up. We'd done a certain amount of orthopedics even, but we would gradually give up the orthopedic aspects, and we'd gradually give up the doing any sections or anything. We preferred not to do those. So most of our surgery then became abdominal surgery and doing general abdominal surgery, a lot of breast surgery, no chest surgery. But as far as head and neck surgery, we did a lot of thyroid surgery, did parotid surgery, and so it was quite a variety of general surgery. As far as chest surgery, gradually we had a chest surgeon in the area who did some lung surgery, but we didn't do any heart surgery. In fact, in Worcester, in my residency, there was very little of any kind of vascular surgery. Dr. Dunlop was doing some at Memorial, I believe, but there was a Dr. Paul Ware who came into Worcester and established himself at St. Vincent's. He was one of the earliest cardiology surgeons in Worcester. But there was fairly little at Worcester City in my residency. There were a little bit of the surgery, heart surgery that was done was mitral commissurotomies that were being done there, and there were a few coarctations, the aorta they did, but there was very little vascular surgery. So in my practice surgeries, we did no vascular surgery. We did ligation stripping, varicose veins, and things like that, and did a few embolies, but there was very minimal vascular surgery. So it was mainly abdominal, and a lot of, we did a lot of breast surgery and so forth.
You had also mentioned that you had a family throughout
Yeah.
medical school. You got married last year at medical school, was it? Or?
I got married 2 days after I graduated from medical school.
Some good timing for you.
Yeah. I met my wife when I was a senior, and at Georgetown. We got married 2 days after I graduated.
How was it balancing your personal life with your professional life?
Well, I was very fortunate because my wife, being a nurse, and she knew what what doctor's life was like, and she adapted very well to it. We're married now 48 years and have raised 5 children. When I was a resident at City Hospital, our daughter was born, and 2 years later we had a son who lived only 16 days and died. He had my wife might have had German measles and during her pregnancy, and Kenneth was born with multiple cardiac anomalies and also patent ductus and so forth, and he lived 16 days and died. And so after that we had another son, Stephen, and so then in my last year we had our daughter Joan. So we had 3 children when we came out to Webster. Our youngest was 6 months old. She's now 41, I guess, 43. She's teaching. She's a fourth grade teacher, and her daughter is a senior in high school. But it's my family adapted very well to it, and my wife too. When we built our second home, our kitchen was set up such that my wife had 2 food warmer drawers because I wasn't always home for supper, so that the family would have dinner and my wife would have my supper in the food warmer drawers. And to this day, we still have the food warmer drawers, but our eating styles.
Are they in the oven? I don't even know what these are.
Excuse me?
Are they just like a warm?
They're right under the oven. You have the setup, it's the built-in oven, and then under the oven is the food warmer drawers.
Yeah.
So my wife stayed at home, and she was, I used to say she was a homemaker. She used the term she was a home coordinator. And I've always considered my wife my co-equal in the sense that she's a very, she'd like me to tell you, she's a very intelligent woman. She helps me with my crossword puzzles because she comes from New York City, and her familiarity with the theater is, I haven't met anybody who was her equal. She gets the Sunday New York Times, which she reviews quite thoroughly, and especially the entertainment sections, and she's well versed on the theater and so forth. So she was tremendous for raising the children. I respected the fact, and they did, that my wife and I took times off together with another colleague in town and his wife, and so we would travel. For example, we'd go to Aruba or something for a vacation. But as a payoff to our kids, in 1966, when I was installed in the Merton College of Surgeons, we took all the kids, and except for our youngest daughter now, who hadn't been born then. But we took 4 of our children, and my mother, who was 70 then, came along. She'd never flown before. And we flew out of Boston to Anaheim, and we made a trip there around Disney World, and then drove up the coast, and it was quite an experience for all of them to see me installed in Merton College of Surgeons. So this was a vacation which was very memorable for the children. They'll never forget that. And then, as I said, we'd alternate. My wife and I would take a trip, and then we'd take a trip with the kids. So they were not deprived at all. But we didn't travel like I see people traveling now with the little kids on their back and everything. We didn't do that. My parents would come and stay at our home, and they'd babysit the children, and when we were away, and then other times would take the children, but we never took them as infants. They would go with us when they were 2 or 3 years old or whatever. And they've been to Florida, they've been to Disneyland in California, Disney World in Florida. They've been to Nassau with us. They've been to Puerto Rico with us, and so they've had a good life. And when they were in college, they had student trips to various places. So, but we had a balance, I think. When I first started practice, there was an older doctor who told me that I should be careful because your children are going to be up and grown, and you'd better spend some time with them because all too fast they're up and grown, and you're going to miss not having them. And I find that that is partly true, that they did grow up so fast, and I only went to 1 or 2 ball games to the Red Sox with my son Steve, and I probably didn't spend as much time as I should have with him, but I was very busy, and I thought I did the best I could, and he's spending a lot more time with his boys than I did, but I think they all respect I was a pretty good dad, and still am to my children and grandchildren, so. But some are as good or better, I'm sure.
Let's see, so I'm sure over the years of practicing, you've seen a ton of changes in your field.
Yes, I certainly have. And as I said, I think I like to look at many of them as being change for the better. And I try to give a certain appreciation of what the changes for the better are, where trying being realistic that some of the things in my own opinion, not as optimal. What are better, I find that in general in surgery, I think the ancillary services have improved so much that, when I first started practicing in community hospital, we were practicing, I think, at a level comparable to our contemporaries in Worcester, and we were expected that our standard of care was comparable to the community, which I felt it was. It was as good or better, because I feel that coming from Worcester City Hospital, where I saw a surgeon doing a gastrectomy or a colon resection or gallbladder with a resident or with an intern, that our situation where one board-certified surgeon was helping another was comparable to that. The only place where I felt perhaps we were trying to maintain a comparable level was with our anesthesia department. And we would import people from Worcester, anesthesiologists, because this was a field that was gradually evolving. At City Hospital, in fact, we had people who had already, they were board-certified anesthesiologists, but there were still a few in the department at City Hospital who were converted from being general practitioners, who then took additional training in anesthesiology, and they were very good with their limited experience, but they knew their limitations, but they were good in what they did. And some of them who were not board-certified anesthesiologists at City Hospital, for example, gave beautiful spinal anesthesias for the lower abdominal surgery or for hernias and that sort of thing. But then we saw that the board-certified people were doing endotracheal anesthesias and so forth. And it was the development of different machines for assisting with the anesthesia and so forth. So this was, I could see there was constantly an improvement developing in that. And I think that one of the big adjuncts to our surgery, and general surgery that I saw developing was in anesthesia. And I think it was far more reassuring to us that we had people who were very competent giving the anesthesia, and that they were well trained. And so I think the advances in anesthesia were certainly complementary in a great extent to surgery. So the surgeons cannot take all the credit for the procedures they were doing, because they had better workups from the internists. They had more help from their anesthesiologists. And as I said, one of the other things that was developing at City Hospital too, as I finished my last year, was the recovery rooms. And when I started practice in my community hospital, we didn't at first have a recovery room, so we had to keep the patients a little longer near surgery, near the surgical suites, and then many of them went back even to a room and had somebody monitoring them at the bedside in their semi-private room. So it was a few years coming before we got a recovery room. So I saw a lot of improvements in the anesthesiology aspects, and that was one of the big, I think, advances for surgeons in all fields, was they have better services in the other departments.
Technique changes.
Well, technique changes. It's very interesting, because when I was a surgeon, when I was a resident at City Hospital, we observed the people with their techniques. Now, Dr. McCready came from Mayo, and he did a lot of radical neck surgery, and there was nobody in the area who was his equal in doing radical neck surgeries. He trained under the guys who wrote the book at Mayo and so forth. And I remember helping him on a number of these things. And I remember later going into practice and seeing, 20 years later, seeing an otolaryngologist doing this procedure, and I'd be assisting him, and they'd be doing it competently, but they were not in the same class with what I saw done before. And so this enters a little bit of prejudice where we saw these people that we had great admiration for. And Dr. Croce was a tremendous surgeon. He was very meticulous. Now, in his, he would start a procedure and he'd clamp and ligate every bleeder, that even a capillary practically. Now, as time went on, surgeons doing now have the cautery. They have improved cutting procedures with I guess the cautery knife even cuts and coagulates the same thing. So there's been improvements in this. Now, as I was finishing my years in surgery around 88, 89, the onset of laparoscopic surgery was coming about. And I could see that this was something that I probably need additional training in, for one thing, because I was brought up on exposure. People that I trained with felt big surgeons made big incisions. And there was an example where somebody had gone once to mention a case that of Sir Anthony Eden, who was a famous person in England in World War II and afterwards, had come to the lady clinic, I guess, because he had had gallbladder surgery done in England that had some complications, and the complication was, I guess, that his common duct was damaged. And the first thing I recall someone mentioning at lady clinic was the incision wasn't adequate. And this is, I remember helping someone when I was a third-year resident, helping a fourth-year resident surgery, doing a procedure, and Dr. McCready came in the room and says, "Step aside, your incision's not big enough." So he extended the incision another 4 or 5 centimeters. Now, it was because adequate exposure was the prerequisite for doing a thorough procedure. Now, we have to accept the fact that there are people now trained in laparoscopic surgery who can match anything that was done up to a point for what was being done in my era, except that even they concede that they have to get patients' consent that they may have to do an open procedure. Now, a lot of these things are still, in my estimate, it takes some judgment to decide when you have to make an open. And I read in the journal of the American College of Surgeons that they do have their share of complications with the trocar insertions damaging various internal structures for laparoscopic surgery. So there's a certain learning curve or whatever else, and so I'm not so sure that I still find that laparoscopic colectomy is comparable to an open procedure. But what was developing in my era more that we adapted to was to using the stapling procedures. In fact, I came here to one of my last teaching session, last learning sessions here was a session downstairs in the lab for one of the for intestinal surgery for stapling, and it was put on by a program here at UMass, and they had greyhound dogs that were used. They were anesthetized and everything else. We don't want to tell the anti-vivisectionists but I don't know why they'd object to them, because the animals were under anesthesia and they were sacrificed after the procedure. But we did bowel resections and stapling. This was a great improvement. It's certainly for any type of colon surgery, gastric surgery, it did speed up the surgery. So I adapted to that, and I accepted that as a tremendous improvement. The stapling techniques were a definite improvement, much faster than any kind of suturing, intestinal suturing and anastomoses would be. So that was a definite improvement. But as I said, in my later years, when I could see laparoscopic coming, I was feeling that I probably would definitely, because I was doing a lot of gallbladder surgery, and I felt that probably I'd have to take time off and proceed with that. So, but I was deciding even during that time in 88, 89 that maybe it was time to make a career change. There were other factors too. With Fallon in the area and attracting a lot of patients to the HMO, my referral base was changing. and so forth. So there were other factors coming into deciding to make a career change. And solo practice was becoming very difficult, almost prohibitive from the standpoint of cost. And the latest article, Massachusetts Medical Society sends, and I recently received and read one of the feature articles there that's presented about the overhead that's troubling practitioners today, the increased malpractice costs and the cost of operating an office. In the last few years of practice, to maintain a secretary and a practical nurse to help me on procedures and so forth, my office overhead was getting very heavy. And I think the last year of malpractice premium cost was something like $37,000. And so when you looked at what your overhead was going to be, and I had friends at Fallon whom I talked to, and I met with them, and Joe Podbilski was a very dear friend who has since passed away, but and I knew him quite well, and Bobby Maher, who was a friend of mine from way back, had worked for my father at the grocery store, and I knew him very well. So when I called Joe Podbilski and said I was interested in something with Fallon, he said, would you still want to do surgery? And I said, well, what other field is it? He said, well, we're starting up occupational medicine. Would you care to come into that? And I said, what would I be doing? He said, well, we could relegate to you the trauma cases, the lacerations, the sprains, strains, the burns, and so forth. So that's when I switched, and I gave up my practice in August of '89, and I went to Fallon September 1st of '89 as an occupational medicine physician.
And you stayed there until?
Stayed there until February of '97, and
wow.
And it was a nice way to wind down my years of practice. My years. When I left my practice, I conveyed all of my records to Hubbard Regional Hospital, where I had practiced, and they became custodians of all the records, which fit in with what the requirements of the Board of Registration was about where your records should be and so forth. So I had a lot of filing cabinets, which I donated to the record room at the hospital, and in return for that, they also accepted they agreed to be custodians of all my records, and that was a good feature then when I left Hubbard, where I had been chief of surgery and president of the medical staff, and I had enjoyed my relationship there, and I left when I didn't have to leave, but I left when I was still at the top of the heap, so to speak, and I could make my own choices. And I was very pleased with my Fallon association. It was a wonderful 7 years that I spent there. I made a lot of friends, and it kept me stimulated because I had to go back to the books and read up some of my orthopedics and the carpal tunnels and the tennis elbows and the rotator cuff injuries and a lot of things that were coming down, a lot of the back problems and knee problems, ankle problems, and so forth. And so I had referrals there for minor surgery that sent me for, I practiced out of the Auburn Fallon Clinic. And so it was a wonderful 7 years, but then, as I said, I turned 70 in '97, and I'm 74 now, and I feel I'm in excellent health. My father lived to be 99, and I think my mother lived to be 91. I have a brother who's 84, and he's pretty active, and I think, and a younger sister who's 69. And 3 others have departed, but I think I'm fortunate to have some good genes, but I don't disregard that. I don't smoke. I smoked cigars for some years. I gave that up after my father passed away. We used to smoke together, but he passed away in 1986, in his 100th year. I gave up smoking cigars, and my wife was happy about that. So, and I'll take a moderate drink, maybe 1 or 2 drinks during the week. If I go out, I'll have Absolute Tonic or a Manhattan. So moderation, I practice moderation, and I have a very optimistic, very cheerful frame of mind. I'm very appreciative of my God-given blessings, and I have a certain basic religious philosophy that I'm appreciative of what I've been endowed with. I don't take it lightly. I feel I'm blessed with good fortune and health, and having a wonderful wife and wonderful children, and so I think it's I'm a very happy person, and I wish well for everybody. I wish.
We only have about 5 minutes left. And
Go ahead.
question I want to make sure I ask you is
Sure.
what sort of advice you would have for a young medical student or young physician just entering into the profession?
Well, I think it's to be true to yourself, and this is, I think, the essence of a person's character. As there are certain values that I have in life, and the first standard I have is truth, because as a Catholic, I feel that my Christian philosophy is of a search for truth, and I think with truth comes true love. It's genuine relationships, and for a young physician, it's being truthful, first of all, to yourself in your dedication to what you're doing, and to the persons do you associate with. You choose a wife. You feel there's a certain this commitment relationship you have is one where you're truthful to one another, and it's you give the best of what you have. I had a teacher once who said to me that you set very high standards, and you say, well, you do the best you can. Our youngest daughter once driving back from the city with me, and she says, Dad, she says, I think you're the best doctor in the world. And I said, Laura, first of all, let's get one thing straight. I'm not the best doctor in the world. I said, but I'm the best that I can be. And I set a very high standard for myself. And I'm realist to know that I'm not the best, but I'm the best that I can be. And this is, I asked of my children, and I was always there to give them counsel, advice, but they were always able to make their own choices and so forth. And they've been a great source of satisfaction to me and pride. And so I feel to a young physician that you focus on the important things. The important things is that you direct yourself to acquiring the education you need, that you can be the best that you can be at what you're doing, that you're true to yourself, that you're the one thing I don't like in life is hypocrisy, where people preach but they don't practice. Not that I set myself up as a paragon of virtue in any regard. I have my own sins and failures, but you try to set standards. In fact, you give me a difficult question because I'm not an easy person to live with in regard that I'm a type A. When I say I'm going to be somewhere at 8 o'clock, I'm there at 8 o'clock because I was trained that way. And as I said, you had in the questionnaire something about in your practice, did you make house calls? Sure, I made house calls. I made nursing home calls. I enjoy practicing in a community, for one thing, because I can't drive down the street without knowing somebody in Webster and Dudley in my community. The fellow comes to check my boiler and says, you remember that Saturday when I came in with this terrific lip laceration and you sewed it up, you can't even tell. He says, you know what, Dr. Szlyk, he says, when I go to church, he says, I even pray for you. I said, geez. He says, if you ever need service for your boiler, 3 o'clock in the morning, he says, don't ever hesitate to call. You know, and I was on the school committee for 10 years, and the school superintendent, I operated on him, and I'm a director at the credit union, the chairman of the board, I'm vice chairman of the board. I operated on him, and the fellow sits across from me, I operated on him. I've had a great involvement in my community, which has been a great return of satisfaction to me, because I've always felt that I've been true to my service, and as I said, one of the things when I'd be getting dressed up in the morning is that I always said my physician's prayer too, and because I felt that my religion was a source of strength to me too, to know that there's a dimension beyond our own capability, and somewhere is this guiding force that tries to sustain us when things are really tough, and everyone faces those times. As I said, one of the great sadnesses in my life was when I was a resident and we lost our first son. But after that, we had another son, and we had 3 more daughters, and life has been good to me, and I hope I have many more years to go, but whatever I have, I'm going to make the best of it. And I enjoy coming and seeing somebody like you, because you're the future, and as I said, I have my brother John, who's 84, has a grandson whom he helped put through George Washington Medical School, and who is now a senior urology resident at GW. And his sister, my brother John's other granddaughter, is a sophomore medical student at George Washington, and she will often call my brother and say that she assisted her brother or observed surgery that he was doing. So we have a continuing generations following in medicine, and Gregory went to Brandeis, then he went to George Washington, now he's in urology. He was an Eagle Scout, a very determined young fellow, and so I think the medicine attracts some of the finest, and I think it's a great vocation, and I think that it's an opportunity to make the best of your